Welcome to Dr. Heidi Hutman. She is at the Temple University School of Education. She is an assistant professor, and she is the recipient of many awards, including Outstanding Publication Award from the Section on Supervision and Training of the American Psychological Association. Also, vast experience in multicultural supervision and multiple publications. So today we're going to be talking about helping supervisees identify and manage reactivity and countertransference.
This is a really important topic, and yet one that we don't discuss often enough. And so I'm really looking forward to helping folks think about how in their role as supervisors, they might be able to both identify and respond to supervisees' experiences of countertransference and reactivity. We're going to start with a case example. You have a supervisee who's 35 years old, Black, cisgender, heterosexual female, and she meets with her supervisor, you, who in this context is a 40-year-old white cisgender heterosexual female working with the supervisee to accrue hours for licensure. So post-master's degree, supervisor has been working at the Community Mental Health Agency for 5 years, and this agency serves primarily low SES clients. Working with the supervisee for roughly just over a month. The supervisee comes to session and appears preoccupied. The supervisor asks the supervisee what happened, and when she finally shares what's on her mind, she has tears in her eyes. She explains that she just finished a session with a client with whom she's been working with for several months, an 18-year-old Black heterosexual cisgender female. The client came into session and announced that she had gotten, in her words, knocked up, so she was pregnant, and was not sure if she wanted the child. The supervisee disclosed to the client in session that she had also had an unplanned pregnancy around that age, and under pressure from her family, she had had an abortion, but that she continues to regret that decision even till this day. Let's pause for a second and really reflect on the case. In hearing about this case, what are your reactions? What stands out to you? Thinking and taking for a minute in your respective groups, what might be causing your reactions? And also, are there things that you would like to say in this moment in kind of putting yourself in the supervisor's shoes? Much of what's kind of going on in this vignette really falls under the construct or this term countertransference, which is also often interchangeable with reactivity. And so what is countertransference? Well, countertransference really doesn't exist without its kind of counterpart, transference. So briefly, transference is when the client has feelings or reactions that they transfer onto their therapist, often based on earlier experiences with significant others. Countertransference is very similar, just in the opposite direction. So in the context of countertransference, it's the therapist and the supervisee, in this case, who's having feelings or thoughts or reactions in relation to her client based on their own early experiences. Countertransference is a term that was really originated by Freud, and it was really seen as something that would interfere with therapy, and the cure was to go have your own analysis. However, in more contemporary times, it's not seen as a barrier to treatment or something that you have to cure per se. It's really viewed as important data, giving the therapist insight into how others in the client's world might experience the client. As I noted, it's kind of interchangeable with this term emotional reactivity, and we'll talk a little bit about how that's a pan-theoretical construct. What this means is that it applies to all theories. And so it's really not about if a trainee therapist will experience countertransference, it's about whether they will recognize it and how they will address it. And that's really where the supervisor's role is important in that context, in helping them recognize and respond to those issues. What does it actually look like? What are some clues that this might be going on? So some kind of giveaways might be that the supervisee is avoiding certain topics in therapy and or supervision. They might experience really intense emotions, so feelings of extreme sadness, anger, anxiety, boredom, excitement, as well as other reactions. They might feel that it's hard to remain present in session. So noticing that they're distracted or preoccupied, just really not kind of there and showing up fully in their work, either with you as well as in session with their clients. They might struggle with boundary issues, so difficulties keeping the therapeutic frame, letting sessions go on too long, contact things to clients in between sessions in ways that don't necessarily feel clinically appropriate or necessary. And they might also just feel kind of paralyzed or stuck, feeling a little bit like they don't know what they're doing. They're feeling de-skilled and questioning their effectiveness.
Heidi, sometimes supervisees may not be aware of these feelings, though. They may occur, but the supervisee maybe isn't aware.
Right. Much like with our clients as well as ourselves, sometimes something just feels a little off. We might feel like we're really passionate about the work, and we might not recognize that this is actually coming from a place of reactivity. And we're going to talk in a bit about how you might kind of facilitate that exploration and bring some of those feelings to the surface when they're kind of being suppressed or just the supervisee's not aware of it.
Right. The importance of the supervisor in this role in terms of noticing, as you mentioned, deviations from normal practice, that kind of thing.
Definitely. So just as a kind of check-in, or, I like to call it a pause and ponder, if you might in your groups really think about when you were a supervisee, what topics did you avoid in supervision and why? Were there times when you found it difficult to remain present in supervision, in therapy with your clients? What are those times and how did you handle it? And also in thinking about what impact you think it had on your work with your clients as well as in supervision, thinking about your relationship with your supervisor, as well as kind of the focus and things you were able to talk about or not talk about in supervision. So hopefully you had some good discussion in your groups. We wanted to talk to you a little bit about some of the research in this area. So even though we know that trainee countertransference or reactivity is inevitable, there's not a ton of research on this topic, perhaps because of what Carol was saying about how it's often not something people are aware of. So those that have investigated this kind of phenomenon suggest that it is an important area of conversation and dialogue for supervisees. And so it's an important supervisory skill for supervisors to be able to initiate those discussions. Trainees have been found to underreport countertransference reactions, often because they're scared and they are able to notice it. They might think there's something wrong with them or that this means that they're not being effective as therapists. And given the evaluative context of supervision, it might be difficult to kind of say, hey, I'm really struggling with this. However, when they experience their supervisors as open to having that conversation, they're more likely to talk about it.
And I think that's an important issue to highlight, that the trusting relationship and the respectful relationship in supervision is hugely facilitated.
Absolutely. It's so central to so much of the work we do, but particularly when we're having these intense reactions that are so uncomfortable and unpleasant, to have a supervisor who really normalizes that and says like, yeah, this is part of our supervision work together. And I really want to hear about this because this impacts your training.
And furthermore, I have these kinds of feelings too. Let me give you some examples because none of us is immune from this.
Definitely. And that's a great bookmark for our discussion later on when we talk about kind of the supervisor's own feelings vis-a-vis the supervisee and their clients. And so, the supervisor might be reluctant to address countertransference and kind of trainee reactivity. And that's also fairly common due to the fact that, there is a lack of training on this topic, as well as a supervisee, as Carol indicated, a supervisor might have their own reactions.
Another variant, which we see a lot in California, is that the phenomena is not really recognized.
Right.
That supervisors are trained in models that have not been attuned to countertransference or emotional reactivity particularly. And therefore, it makes it even more difficult for the supervisee to disclose. So as supervisors, we need to be very thoughtful about that and view our training through that lens.
Carol, you raise a really important point because I think about how what happens when you're working potentially from a manualized approach, one that maybe doesn't kind of take into account some of these very important but hard to kind of nail down phenomena. And so maybe an additional clue could be that you're noticing the supervisee is really clinging quite rigidly to the manual to kind of manage their own reactions internally. So that's something that might be important to kind of think about.
And one more thing about the ethical aspect, and that would be that it's very critical to understand these feelings, because in some instances they could even lead to ethical infractions. If there's, for example, a form of attraction like sexual attraction, and the supervisor is not interested or doesn't support the supervisee's discussion or identification.
So to be able to prevent those feelings from becoming ethical transgressions, you really need to be able to have a place that normalizes the feelings, but also clearly, where the supervisor can clearly say, it's okay to have these feelings, of course not to act on them. But if you don't have that outlet in supervision, that's a huge risk. And so for all of these reasons, addressing countertransference, supervisee reactivity is a core competency. We're going to talk a little bit now about how to respond or to address countertransference or reactivity in supervision. Wanted to just take a couple minutes, though, to be able to think about what your thoughts are so far, questions that are coming up for you. One way to think about how we might address countertransference or reactivity in supervision is through using Ladany, Friedlander, and Nelson's critical events approach. So the first step is to recognize the marker, the statement or action or inaction in supervision that suggests the need for the supervisor to respond. In the context of countertransference or reactivity, markers could be, the supervisee announcing intense feelings, as well as potentially deflecting, avoiding discussions, indications that the supervisee is not present in their work. In the next slide, you start with the marker, and then you really talk about the tasks before you and responding to that marker, and we'll get there in a second, as well as the resolution. So how do you kind of come to a place where you feel like either the supervisee has increased understanding, increased resources, tools, has a sense of where to go next with the client and with managing their more intense reactions. So I'll give you a minute in your groups to really kind of think about what the marker might be in this case example. Let's say that in this example, the marker is some indication that the supervisee is preoccupied. And then for me, thinking about this, the confirmation that something is going on is when the supervisee tears up, right? So both of those pieces seem important in terms of markers that the supervisor is going to need to respond with some type of supervisory intervention. So once that marker has been identified, the job of the supervisor is fourfold. So wanting to explore the supervisee's reactions, really attending to the feelings, thoughts, behaviors, as well as the physical sensations. Like, how does their body feel when they're kind of thinking about this case? How did they feel in session? What came up for them on a visceral level?
Heidi, can we stop for a second?
Yes.
Is this sort of a critical point? Because isn't there a possibility at that very moment that you could slide into psychotherapist?
This is a great point to emphasize. The supervisor wants to be managing the countertransference reaction, which may come from a deeply personal place. In fact, it often does, but really focusing on how it informs their work with that client. So when you talk about this, it's important to be able to hold the complexity that is balancing, hey, there's this thing that's really interfering with your work, or it seems like something's going on for you. Can we talk about this a little bit? And also being able to recognize, well, it sounds like these are some really intense things that are going on for you personally. So I'm wondering if it might be helpful to have your own therapeutic space to process those deeper underlying issues.
Thank you. Very helpful.
As Carol indicated earlier, the alliance, the relationship, the ability to create a safe and trusting space where you're going to be able to be able to not judge the supervisee for those reactions. So really being able to understand that this is a normal, universal, inescapable phenomenon. And if anything, the supervisee is demonstrating a lot of courage in being able to talk about this with you in light of the power differential. Being able to normalize the experience, as we said, so countertransference is a universal phenomenon. You might be able to model your own experiences with countertransference and share that, as well as working through it with the supervisee. You might incorporate mindfulness and meditation if the supervisee is finding it difficult to remain present in supervision as well as in therapy, managing anxiety, engaging in self-care, either through, and therapy, seeking out their own therapy is part of that process potentially for them, as well as thinking about like, how does this make sense in their theoretical orientation, even if they don't necessarily, if their orientation doesn't necessarily make room for that explicitly, really being able to tie it to theory so they can feel more purposeful, as well as thinking about how they might use this experience to in kind of relation to other clients that bring up intense reactions for them.
Can I just ask you to clarify one point? I think it's important for our supervisors to know we're not suggesting that every supervisee who experiences countertransference needs psychotherapy.
Absolutely.
And there are situational setting situations which make it very difficult to say that. So they might find it more appropriate for their settings to say, I've noticed that you're having these strong reactions in multiple clients and it's impacting your client work. Therefore, I think you have to consider other options for dealing with this, because we have to cover our 9 clients in this hour, and we've got, not to be cold, but to be clear, it's not simply that countertransference requires psychotherapy.
Definitely. There are a variety of different spaces that you might have your supervisee seek out. There are online communities, there's peer support and supervision. I know that folks who work in trauma as well as in treatment facilities often have had their own recovery experience or own traumatic experiences to work through. And so those additional supports can be really helpful for sure. And definitely it doesn't always mean therapy or else. In fact, supervisees can tell you that they have had similar experiences to their clients, but they've worked through it. And every now and again, something comes up that triggers them a little bit more, but that they feel like they have it relatively sorted through and just need some kind of additional space to work through that.
Thank you.
Thank you. So additional questions that you might ask in kind of exploring countertransference or reactivity. So again, thinking about how this might help you in identifying a marker if you think something's going on, as well as kind of engaging in the tasks and getting to a resolution. So you might ask, like, how does this client feel familiar to you? Who else in your life makes you feel this way? How is your work with this client different than with other clients? You might say, I noticed that you're really having trouble ending at 50 minutes with this client. Does this client feel different for you? Are there ways that this client reminds you of somebody else in your life? To what extent does it feel harder to leave this client at the office, right? So do you bring this client home with you relative to other clients? Do you notice yourself having trouble keeping the therapeutic frame in terms of those boundaries? Maybe you're clinging too rigidly to the frame, so to speak, and from a context of manualized treatment. So maybe you're really finding yourself very rigidly adhering to a manual, whereas maybe you're more flexible and know when you can kind of veer off course with other clients. If this person were not your client and you met them in your daily life, how would you feel about them? It can be a helpful question to ask in general. So getting to these more cautionary pieces, you really want to keep in mind your own boundaries and the purpose of supervision. Oftentimes, we know that folks in community mental health agencies are running on borrowed time. They have a lot to do. And so there's an abundance of clients and case management issues to get through. So it's important that you be able to model keeping those boundaries so that the client can maintain boundaries in their own work with clients. As we kind of indicated, a supervisee's personal experiences are relevant insofar as they impact their work with clients. And that is really what your work is with the supervisee. It's not about giving them therapy. It's not about delving into further exploration around their personal issues. It's really about helping them manage this effectively so they can show up for their client. Again, supervision is not therapy, and it is the supervisor's job to really recognize when there are pieces that require other spaces to process, right? So whether that's therapy, whether that's online communities, whether that's bibliotherapy for the supervisee, delving into the literature, etc. So recalling the case reviewed earlier and keeping in mind what we've just reviewed in terms of the critical events approach and the questions to ask, and also those really important considerations in terms of your own boundaries and the boundaries between supervision and therapy, how might you respond to the supervisee? So we've identified the marker, and so what might you consider in responding to supervisee, and how might you do that? This discussion really wouldn't be complete if we didn't talk about supervisor countertransference or reactivity. And we've kind of planted seeds in the earlier part of our conversation about the possibility that you might be having your own reactions to your supervisee and to their clients, and that might make it difficult for you to address some of these issues in ways that really allow you to kind of be a competent supervisor. So again, this is unavoidable, right? And so it's unavoidable for you too. Supervisors are humans and they've had their own lives that they bring into supervision sessions. So managing that the same way you want to help your supervisee manage their own personal life experiences is really critical. It has been referred to as supertransference. Some reasons that this might happen for you as a supervisor include feeling stressed about things unrelated to supervision. So we all know that we are doing a million trillion things before and after supervision. And so it can be hard to kind of just really orient yourself and be present in that moment. Feeling disappointed that the supervisee is not taking the work seriously. So you might just feel like they're not caring in the way that you want them to, and that the investment in helping their clients isn't there. Maybe the investment in supervision and using supervision isn't there. You might kind of overly connect with the experience of being a neophyte clinician, neophyte meaning a beginner level clinician. So really remembering your time when you were, just kind of feeling like you were floundering and fumbling around and trying to find your own way. You might have a lot of identification with that experience. You might have kind of a very strong commitment to the supervisee becoming a better therapist. And again, it's not that being committed to improving the work, your work as well as your trainees' work is an issue. It's really that intensity of that reaction signals that there might be something more going on other than just wanting them to do a good job. The research suggests that supervisors tend to deal with their own countertransference through consulting colleagues or addressing the issue with their supervisees. It's interesting, if supervisors are struggling with their own stuff, that might actually be of value to explore in their own therapy. They don't end up seeking that out. Thinking about what we recommend to our supervisees is hopefully advice that we can take on our own if it feels helpful and appropriate. Supervisor countertransference has been found to be triggered by a number of things, and this includes but isn't limited to a supervisee's interpersonal approach or dynamics. So just something about their personality kind of triggers you, might remind you of somebody that you had strong feelings about earlier on in your life or in your outside life currently. The supervisor's own personal baggage, as well as experiences with former supervisees. So we bring those experiences the same way our supervisees bring experiences with former supervisors into the work. So they might have had a supervisor who is really unwilling to discuss some of these issues, and that might make them especially reluctant. And you might have had an experience with a supervisee that makes you reticent to kind of have these conversations. So it can go both ways. Supervisees might have more competence than you in a particular area, and that can feel very threatening to the work. In terms of cultural countertransference, you might have reactions to supervisees who occupy areas of privilege relative to you and or belong to a cultural group that you don't have a lot of familiarity with. So you might kind of feel stuck in terms of how to work with those issues surrounding cultural difference, as well as feelings of sexual attraction. So we are human beings first and foremost, and so we're not immune to any of those feelings, as uncomfortable and unpleasant as they are at times. Some of the consequences of supervisor countertransference might include playing favorites, as well as the other end, scapegoating supervisees, competing with others in the supervisee's life. So really wanting to be kind of a priority and of central importance. It might be other supervisors that they have or other staff at your agency, having unrealistic expectations of the supervisee, wanting to be liked so badly in terms of really wanting the supervisee to feel positively about you. And so it might be hard to challenge the supervisee or discuss things that might provoke reactions for both of you that are not pleasant. Again, supervisor reflection. So really being able to recognize these things, having peer support, consultation groups, etc., where you can really think about how this is playing out in your work with supervisees. And self-care is just so important as well. So let's return to the case and add a layer here. When hearing about this supervisee and her client, you find yourself feeling irritated and a bit resentful. So again, these might be your markers if in thinking about the critical events approach, right? So something's off. You're feeling a little bit miffed about what the supervisee is discussing. And your first thought when hearing about the case is, great, another person who got pregnant and didn't even have to try. Now, what you know privately about your own life is that you and your partner are currently undergoing fertility treatment, something that many couples struggle with, and have been trying to get pregnant for the past 3 years. You are exhausted emotionally and you're depleted financially. You want to convey empathy for your supervisee and help her address her concerns, but you're clearly distracted. What would you do? How would you feel? What other reactions might you have? Just because the supervisor is feeling a certain way doesn't mean that you might feel that way. And so if you can kind of take a moment. Some final takeaway points about the topic of countertransference and reactivity. I encourage you to think about, both in your groups as well as in your respective employment settings, how might the framework and questions reviewed today be helpful to you in your work with supervisees? What personal comfort level do you have in addressing supervisee countertransference and reactivity that might come from your own stresses at work, the constraints at your site, as well as your own kind of personal approach to therapy and supervision? Was supervisee addressed in your training, if at all, and how so? What barriers have come up for you in the past in trying to address these issues with your supervisees? And how do you imagine kind of dealing with these issues with current supervisees or future supervisees that you might encounter who are dealing with countertransference or reactivity? How has your own countertransference in your role as a supervisor impacted your work with trainees? And what steps have you taken, if any, to work through your countertransference back when you were a supervisee, as well as currently in your role as a supervisor?
Thank you so much, Heidi. One thing to add is that I think there's the amazing possibility of consultation amongst supervisors in your setting. So that is a wonderful place to get consultation, to reflect with peers or with even your own administrative supervisors about the kinds of things, understanding that it's highly normative.
So having that community of support and idea exchange and dialogue amongst your colleagues and peers is definitely a really important piece to all of this.
Thank you so much for your time, and we really appreciate it.